Hi, my name is Rithi Dipani. I am a student at Bay Path University for occupational therapy, and as a part of my Research 2 course with Dr. Witten, I have composed a research proposal, and I have a presentation here for you today for a grant. So the topic of my research proposal is pain neuroscience education for chronic pain in the pediatric population. All right, a little introduction. Just going to start off with the definition of chronic pain. So chronic pain is defined as pain lasting for 3 months or longer consistently. Chronic pain is a debilitating condition affecting 11 to 18% of children in the United States. Further research also shows that pain is also debilitating in children just internationally in other countries as well. Although right now we're focusing on just in the US. In the pediatric population, as an occupational therapy practitioner, pain serves as a barrier to participating in daily occupations such as activities of daily living, getting up, getting ready, developing that independence and those skill set. School participation is affected. There's a very low or a very high rate of missing school and poor attendance for children that are suffering from chronic pain. They aren't able to participate in sports or other after-school activities. They aren't able to participate in like preferred leisure and social participation. So all these things kind of affect their development and just their quality of life. And as occupational therapy practitioners, it's our job to help them participate in the things that are important to them. So moving forward, multiple research studies show that pain neuroscience education, which I have abbreviated as PNE, to have positive outcomes on pain and disability. So a little bit of background. Like I just said, pain neuroscience education has demonstrated positive outcomes in the adult population, but has a lack of research in the pediatric population. So as occupational therapy practitioners, we want to utilize our diverse skill set to develop a standardized intervention to deliver proper PNE in the pediatric population. So a review of the literature. So I'm going to start with a little bit of what is the problem and why do we need standardization for PNE. So parents and families spend so much time and money seeing so many different practitioners and specialists for an answer for their child and the chronic pain. And many of these specialists resort to pharmacological intervention methods, aka painkillers. So that's what I have first here is that pharmacological intervention has always been the primary method for chronic pain, and this leads to the big overarching word over medicalization. So many kids are just being pumped up with painkillers, and sure, that might be helping with their pain right now, but then you're increasing the dosage, you're not really finding a root to the problem, and it's kind of just slapping a band-aid on the problem. And furthermore, several questionnaires that include the concept of pain inventory and the functional disability index, which are all questionnaires, they show a strong correlation between the parents' score, the concept of pain inventory score, and catastrophizing their child's pain. So catastrophizing is also a huge word that is seen a lot in the literature when it comes to chronic pain in the pediatric population. A lot of parents, which is natural for them to catastrophize the pain that their child is feeling. They're empathizing a lot. They're sympathizing a lot, but this is in fact increasing the pain that the child is feeling. So what is the root cause of this problem? Those chronic pain. It's not necessarily a biological root problem. Environmental and lifestyle stressors that typically cause anxiety and depression can contribute to symptoms of chronic pain. So what do we want to do now with this this proposal that I have for research is that currently there's a lack of standardization or a defined curriculum designed to provide PNE to specific developmental age groups. So a lot of studies show that PNE has positive outcomes in the adult population, like I mentioned before. So we have that, but there are no studies that have a standardization when it comes to the pediatric population. One study that delivered PNE to children ages 9 to 11 revealed that a significant relationship between pain knowledge and pain intensity with a P-score of 0.014, meaning that these kids that had pain neuroscience education sessions reported like a less pain because they understood the source of their pain. So a research question here today is, does pain neuroscience education decrease pain in the pediatric population with chronic pain? So the research proposal here has, the sample size is 45 participants from ages 8 to 12. They'll be recruited from our pain clinic, and all patients will be from the tri-state area, including New Jersey, Pennsylvania, and Delaware. I'm going to skip over the methods for a second, go to the outcome measure. So the questionnaire that we're going to use for this study is the PROMIS, the Patient Reported Outcome Measurement Information System Pediatric Pain Interface. So this is a questionnaire, and it has like a list of like 10 to 12 activities, like daily functional activities that any typical healthy child or adolescent would do. And they have the participant rate if the activity is impossible for them to do, possible for them to do, or just anything in between. So the most important thing here that I found is the participant is kind of reporting what they think they can and can't do, which is most important because we're working with our clients directly, and we want to make sure that they're happy with what they can do and their functional levels. So this is the questionnaire. So back to the groups, 45 participants total that are going to be split randomly via random selection into 3 different groups, 15 participants in each group. Group 1, participants will receive 2 hours of OT Monday through Friday for 4 weeks. Group 2, participants will receive 2 hours of OT Monday through Friday for 4 weeks, in addition to 10 minutes of a PNE educational video session in the beginning of 2 weeks, in the very beginning, after 2 weeks, and then at the very end after 4 weeks. So it's beginning, 2 weeks, video, 2 weeks, video, 4 weeks total. Group 3, participants will receive 2 hours of OT Monday through Friday for 4 weeks, in addition to the 10 minutes of PNE educational video sessions with their parent. So same as group 2, except that the parent is going to receive the PNE video, is going to sit in on the PNE educational video as well, because of everything in the literature that shows the catastrophization that parents have that leads to increased pain. So here in group 1, they're receiving no PNE. Group 2, participants only are receiving PNE. And group 3, participants and caregivers together are receiving PNE. OT sessions are going to include things like strengthening, upper body strengthening, core strengthening, total body strengthening, all those typical biomechanical exercises. A variety of like stimulating functional exercises, like maybe putting on a weighted backpack and going for a walk, because that's something kids would do at school that a lot of kids find difficult. Maybe even holding books and going for a walk, books and binders, sitting in a desk for a long period of time, like a 45-minute class. Maybe like static positions, like standing for a certain period of time, sitting for a certain period of time. Crisscross applesauce, maybe some kids have to do that for like on the carpet in elementary school, since we are working for ages 8 through 12. So that's what OT sessions are kind of gonna be consisting of. And it's definitely gonna be individualized patient to patient. Let's see what else. So the PROMIS questionnaire is also going to be delivered or be required for the participant to fill out at the beginning, before the study starts, after 2 weeks, and then after 4 weeks. So then let's get down to data analysis. So I chose a paired t-test because we want to compare the results from the questionnaire in the beginning, after 2 weeks, and then after 4 weeks. And a paired t-test is definitely appropriate for that. Limitations definitely stand for this study. The first and most obvious one is that pain is subjective. Pain is subjective for everybody. Everybody has a different pain tolerance. We want to make sure that, we're gathering data, and that's why when I chose to do the questionnaire at the beginning, after 2 weeks, and after 4, where we can always compare like participant one's results from the beginning, the second questionnaire, and the last questionnaire, even though it may not accurately be valid or reliable to compare to participants' 2 scores. We can compare their own scores throughout the entire study. Another limitation is that there's an unstandardized curriculum. This just is because kids are always at different developmental age groups, different cognitive levels. So since we're working through ages 8 through 12, an 8-year-old may not understand the educational video that the 12-year-old understands. And for the purpose of this study, we only have the one video. So that's definitely a limitation. In future studies, what we can do is have different videos, one for each age group by year or by grade, so that it can be a little bit easier to understand for the younger kids, and a little bit more mature for the older kids. So that's definitely something to look at moving forward, but it is a limitation that stands right now. And lastly, inclusion criteria for the participants. They'll be between ages 8 and 12. They need to have a diagnosis of chronic pain, and they need to be reporting a pain of at least 4 out of 10 consistently. Of course, I understand it's subjective. And they need to be able to understand English, read and write and English, to complete the questionnaires. Exclusion criteria is that if they've participated in a pain program before, and if they're transitioning, because we know from other studies that hormone therapies do affect pain and in different ways, and we just want to keep that out of like skewed data for this study. So why is this study important? Basic OT methodology, OT values, having a plan of care in place for the pediatric population with diagnosis of chronic pain. We want to have a plan of care in place. We want to have an intervention that shows evidence-based research and has like good results and good outcomes. And that's why we're doing this study, so that OTs elsewhere can look up this study and say, oh, PNE has good outcomes. Let me go ahead and use this PNE intervention. We want to help children increase participation in their daily functional activities and increase school attendance, because, kids are our future. As a pediatric OT practitioner, we just want to make sure that children, adolescents, toddlers, kids can participate in what is most important to them and what can help, achieve their most optimal quality of life. And lastly, the aim for the future is to implement PNE into preventative care. So maybe, this is far into the future, but having PNE part of like a school curriculum or part of a doctor's annual visit, things like that. So preventative care is definitely a big one when it comes to mental health and chronic pain, things that don't have answers such as painkillers do. And these are my references. Thank you.